Hi, thank you all for joining our webinar for referring physicians on biventricular repair. I wanted to introduce our panel today. We first have Dr. Barucham, who is the medical director for our biventricular program. We next have Dr. Mani, who is the surgical director for the biventricular program.
Good morning, everybody.
And I'm Naomi. I'm one of the physician assistants in the cardiac surgery department that helps with the biventricular program. We have a very exciting webinar for you today, and it will be broken down into 4 sections. Our first topic will be an overview of our program, and then we will dive right into which lesions are eligible for biventricular repair. We will move on to discuss some of the unique aspects of our biventricular program here at Boston Children's. And finally, we will wrap up with a summary of what providers need to know about the referral process. Just as a disclosure, this is a webinar for referring providers. So if any family members may be on, or patient families, we just wanted to let you know we will be showing surgical videos. So let's get started with an overview of our biventricular program here at Boston Children's Hospital. So Boston Children's Hospital has been a pioneer in complex biventricular repair. Dr. Mani, why has the Heart Center taken this approach and prioritized this program?
Well, I think that we've all noticed that patients with single ventricle physiology do well early, but develop issues somewhat unpredictably at various ages. And this is really the nidus for us to think about novel ways of reconstructing the heart so that we can use both ventricles. And I think this program started probably in the early 2000s and has really developed quite a bit since.
Thank you. Dr. Barucham, what circumstances should biventricular repair be considered over single ventricle palliation? And what are some of the potential benefits of this repair biventricular strategy?
Thanks, Naomi. I'm going to use a few of our slides to kind of get into that bit of discussion. You guys can still see my slides, right?
Yeah.
Yeah. Okay, good. So this is sort of the range of defects in which we commonly evaluate patients for potential biventricular repair. A very common one is patients with unbalanced AV canal defects, and oftentimes in the setting of either Down syndrome or heterotaxy syndrome. Another one is patients with pulmonary atresia, intact ventricular septum, in whom we consider right ventricular recruitment. There are also, the different variants of hypoplastic left heart syndrome. And then numerous patients with different conotruncal defects, either in combination with a hypoplastic left ventricle or an unbalanced AV canal defect, or some of the more complex conotruncal defects, which, for example, remote great arteries. Double inlet ventricle defects, and then different forms of congenitally corrected transposition of the great arteries. And just for the purposes of our webinar, since we won't be able to get through all of these lesions in one day, we're going to focus on these 3 different lesions in the discussion today. And then we're hoping to have future webinars to sort of dive a little deeper into some of the other lesions. Just moving on, we certainly, we've been doing complex biventricular repairs for the last 20 years. We're now starting to have some data that kind of compares BIV repair to Fontan circulation. And really, that's kind of the big question is a BIV better than a Fontan in many of our patients? That's the question. So this was a nice study that was published last year by our group, in which our ICU group looked at propensity matched groups of 258 patients, 258 Fontans versus 258 biventricular patients. They did find that there were no differences in 10-year freedom from major adverse outcomes or survival. However, there was a lower incidence of liver disease in the patients who had undergone biventricular repair. And that's something that we think about a lot in terms of our BIV patients, is sort of trying to maintain lower IVC pressures. In terms of our evaluation, we typically will have, cross-sectional imaging plus echocardiography, and we'll typically do cardiac catheterizations. And really our 2 big questions are, number 1, is this an anatomically feasible repair? So can all of the pathways be connected up in such a way that a patient can have higher oxygen saturations and, a septated heart? And then the second main question, which is often a little bit more complex, is trying to predict whether or not a patient will have adequate cardiac output after a biventricular repair. So it's anatomic feasibility and hemodynamic feasibility are sort of what we aim for in our discussions. And then we'll, again, use these 4 different imaging modalities commonly. We'll do echo on pretty much everybody. Cardiac MRI and cardiac CT have a lot of overlap in terms of their ability to evaluate patients, but we tend to rely more on cardiac MRI just because it has flow measurements, and so that gives us a lot more hemodynamic data. And then, of course, the catheterization is really very important. Just to mention that we have been doing pressure volume loops. And in some populations, so for example, the CCTGAs with intact ventricular septum, this has given us a little bit of insight into the adequacy of the left ventricle to support a systemic circulation. And then we've also been using PV loops in some of our hypoplastic left heart syndrome patients to understand their diastolic properties. And I believe I had one more slide looking at yeah, I'm going to stop here because I think we have more questions.
Okay, perfect. So Dr. Burkham's already kind of moved us on to our next topic, which we would like to discuss individual lesions that are eligible for biventricular repair. We've already kind of started with hypoplastic left heart syndrome. So Dr. Burkham, can you just go into any more about how we evaluate these patients with hypoplastic left heart syndrome and determine their potential candidacy for biventricular repair?
Thank you, Naomi. So yeah, I kind of just reviewed already sort of the ways in which we evaluate patients. When it comes to hypoplastic left heart syndrome, there are a couple of things that we look for in particular when we're kind of discussing our patients. So one of them, again, we talked about kind of the anatomic information, ventricular size and function. Also, the hemodynamic data is really very important. And so we do have data from some publications that I can share with you here. One of them showed that really a high preoperative left ventricular end diastolic pressure is a risk factor for biventricular repair in patients with hypoplastic left ventricles. We've also shown numerous times, this is actually probably the strongest risk factor for adverse outcome after a complex biventricular repair, is the presence of endocardial fibroelastosis. So EFE really is very much associated with diastolic left ventricular dysfunction. And you can really appreciate here the patients who did not have EFE versus those who did have EFE. There was a really striking difference in freedom from primary composite outcome in this particular study. We also know that left ventricular recruitment can increase the left ventricular size and output in most cases, and we'll probably get into this a little more later on in the discussion. But in some patients in whom we're really not sure if their left ventricle is adequate to support a systemic circulation, we may proceed with an LV recruitment procedure, which aims to increase the volume load to the ventricle. And then we have an opportunity to wait a period of time, see how the ventricle responded, and then reassess its size and function, its diastolic properties, and have a better idea if that ventricle is fit for a biventricular circulation. So when it comes specifically to evaluation of patients with HLHS and EFE, we look at a lot of features as we talked about. So left ventricular volume and output, the presence and thickness of endocardial fibroelastosis. The valves are also very important in this evaluation. So the mitral valve morphology, and particularly how much flow is going across the mitral valve, is one thing that we pay very close attention to when we're trying to make a decision about a patient. Similarly, aortic valve morphology and flow, hemodynamics, as we talked about, and then pressure volume loops in some cases. So I put together this slide, which kind of goes over some of the risk factors for adverse outcome in patients with hypoplastic left ventricles that we've shown in prior literature. And so just to kind of say that, we often look at our left ventricular end diastolic volume index, and we think of that as it's a major piece of information. The challenge with that value is that the normal values for neonates are very different than normal values for toddlers, which are also very different from normal values in older children. And the challenge with cardiac MRI is that we just don't have really great normal values in infants because it's unethical to kind of try to gather that data for infants under anesthesia. So in any case, for the most part, most of the kids we evaluate are in the range of 6 months to 2 years. And so we tend to use a left ventricular end diastolic volume index of 40 mLs per meter squared as a general rule, although the cutoffs really vary and there's a lot of overlap. I wanted to point out that mitral valve effective orifice area we feel is a better indicator of the mitral valve adequacy as opposed to mitral valve annulus measurement. So, and this actually goes for all of the valves, particularly the mitral and tricuspid valve. The annulus dimension may be normal, but the valve might be parachute-like or converge. The flow jet may converge into a much smaller orifice. And so the actual orifice area, we believe, is more important. And we have a study that kind of demonstrated that. There are other risk factors such as right dominant transitional AV canal defects, the ones that don't have a significant ventricular septal defect. As we talked about, high left ventricular end diastolic pressures, left ventricular outflow tract obstructive lesions. And then more recently, we've kind of demonstrated that having a very dilated right ventricle and high right ventricular mass are potential risk factors as well. So that was kind of a very long overview. I'm happy to share these slides if anybody asks me later on.
So Dr. Amani, after that great discussion by Dr. Barucham, can you discuss the surgical strategies for recruitment of hypoplastic left heart syndrome and include some of the patients that have endocardial elastosis fibrosis?
Yeah, great. Thank you, Naomi and Rebecca. This was a really nice segue. You know, I'd like to start by first talking about what are our options. In the past, you know, we were stuck with sort of saying in a neonate, we've got to make a decision. Do we go BiV? Do we go single ventricle? And once you went single ventricle, you stayed single ventricle. You're a Fontan for life. If you decided to go BiV, then if you succeeded, that was great. You stayed as a BiV, but then if you struggled, then you had to cross over to being a single ventricle. And a salvage single ventricle palliation really has a high mortality. And so I think what we should be doing as a field is sort of not putting the burden on that neonatal time frame. And so one of the strategies we started to develop is to say, okay, I have a child with a borderline LV. I don't want to flip a coin to know if this child's going to do well with a biventricular repair in this neonatal time frame. Let's do a single ventricle palliation in the early phase, but keep an eye on the left ventricle, try to recruit the left ventricle, and then make a decision about whether we stay as a single ventricle or do we go to a non-single ventricle option. So this is where the concept of LV recruitment came in. The way it typically works is we do a neonatal stage 1, whether a hybrid or a traditional stage 1, and then at a recruitment phase we do a couple of things. First, we will open up the mitral valve to improve inflow, because we know that a lot of these HLHS patients have abnormal mitral valves. And then through that, we can actually remove the endocardial fibroelastosis. The thick layer, it's pretty impressive, very cartilaginous. It restricts both systolic and diastolic motion of that ventricle. So we remove that EFE, and then we open up the aortic valve. And finally, what we do, so after we deal with the inflow, deal with the outflow, remove that obstructing endocardial fibroelastosis layer, what we can do is try to push flow over into the left side of the heart by restricting the atrial septum. You don't want to completely close it off because we're worried about developing left atrial hypertension. Now, in terms of the type of blood flow at that time, we might do a Glenn. We might leave the RV to PA conduit or the shunt in place. But the idea here is to promote blood flow through the left side of the heart, and with that, grow the left side, with a very careful caveat being that we don't lose candidacy for single ventricle palliation, keeping all of our options open. And this requires close follow-up to make sure that we're not developing left atrial hypertension, which we monitor by looking at the gradient across that atrial septal defect. So now we've done left ventricular recruitment. We can come back in about a year and see how things look. We can look at the response of the ventricle. And if the ventricle has grown, if the end diastolic pressure is less than 13, if it fits some of the criteria that Dr. Barucham had mentioned earlier, we can go to a biventricular repair. If it looks like the left ventricle and the left side of the heart haven't quite met the criteria that we want, but are close, then one of the new procedures that we've started to embrace now, we've done in about 40 patients, is what's known as a reverse biventricular repair, where we use the left ventricle to pump to the lungs. We use the right ventricle to pump to the body. This is it's surgically essentially doing a double switch operation, but in reverse. So we call it a reverse double switch. If we're not happy with the left ventricle as a pumping chamber for both the IVC and SVC, we can add a Glenn, and that's basically a reverse 1.5 ventricle repair. It requires an arterial switch and a hemimustard, techniques that we're very familiar with, physiologically creating essentially like a corrected transposition type of a anatomy to allow that left ventricle to do less work. Finally, if it just looks like the left ventricle isn't recruitable at all, we haven't lost candidacy for doing a Fontan if we monitor properly, and we can always go to a Fontan circulation. If we do this right, we're not adding additional procedures. We're just timing so that the LV recruitment occurs at the time of the bidirectional Glenn. And then we make a decision at the time of when we normally would do a Fontan, so about 2 years of age, and we make a decision about which way to go. So we haven't, if we do this right, we haven't added additional procedures. We've just modified a little bit the way that we approach it. And I think it is clear that the issue here is the diastolic function of the ventricle. That's the biggest concern that we have. Early on, when we were doing biventricular repairs more liberally, we noticed that some of those patients developed some diastolic dysfunction. So we modified our approach accordingly to include the reverse biventricular repair and the reverse 1.5 ventricle repair. I feel like our algorithm has really improved the outcomes over the past few years. And I think we're continuing to try to develop new strategies to prevent recurrence of endocardial fibroelastosis. I think that's kind of the next direction that we're heading in here. And we have some targets, both medical and novel biological therapeutics that I think may help eventually to improve this. So this is really exciting work, and I really hope folks will ask some questions about this or ask to learn more.
Well, thank you for that great discussion. I'd like to move on to our next lesion, which is into unbalanced canals. Dr. Barucham, can you discuss how we evaluate these patients?
Sure. So first of all, I just want to mention that unbalanced AV canal defects are one of the probably most recruitable type of lesions in which we've seen pretty striking increases in ventricular size and output after ventricular recruitment of unbalanced AV canal defects. And in fact, these patients are able to undergo a biventricular repair at lower baseline LV volumes compared to some of the other lesions for various reasons. But some of our research has shown that a biventricular repair of unbalanced AV canal defects have higher survival than single ventricle palliation. And we think that's due to multiple factors. One of them really being that the biventricular repair stabilizes the AV valve function and really can improve how the AV valves function. And also because we know that biventricular repair as well in heterotaxy patients is better. They have 2.5 times better survival than heterotaxy patients who undergo single ventricle palliation. And of course, there's a huge overlap there with the unbalanced AV canal defects. As I mentioned before, we also know that small mitral valve orifice area, both in the AV canal defects as well as those who don't have an AV canal defect, is a risk factor for adverse outcome after biventricular repair. And so we do pay close attention to that. But in the patients with the AV canal defects, and I think Dr. Amani will likely touch on this later, it is a little bit easier to manage a smaller left-sided orifice of a common AV valve, as opposed to just a very small isolated mitral valve. In terms of our evaluation, again, as I mentioned before, we do kind of multiple things. We do echocardiography, we do cardiac MRI or CT, and then we do catheterization. We do rely very heavily and on cardiac MRI in terms of evaluating our patients. So we looked at multiple things in the terms of the data. So ventricular size, ventricular function. We also look at the anatomy of the AV valves, the number of papillary muscles, how much of that AV valve component is overlying the left ventricle versus how much of it is sort of more directed towards the right ventricle. And then, kind of looking at all the pathways. So in this particular example, this is a patient with heterotaxy syndrome who has bilateral SVCs, and the venous anatomy is unusual. And so kind of trying to look at all of that data to understand kind of how long this surgery will take and whether or not it's feasible.
Right. So, Dr. Amani, can you then talk a little bit about the repair of these unbalanced AV canal effect or AV canal defects? And do you use the same parameters to decide about biventricular repair compared to hypoplastic left heart syndrome?
Great question. So I think one thing to add to what Dr. Barucham said is probably the biggest issue here is that left-sided AV valve for the right dominant AV canal defects. And the biggest issue there is single papillary muscle. You can't close the cleft, and that really complicates a repair. And so what we've done is try to develop a strategy that will allow us not only to recruit the ventricle, but to recruit the valve as well. So what does this mean? If I have a child with an unbalanced AV canal defect where the left side of the valve is small, I can grow that ventricle and valve simply by forcing flow into that ventricle, but not completing the repair. And the way that we do this is to close the atrial septal defect and bring the leaflets together, separating the complete AV canal valve into two separate valves. And I tend to cheat that patch, that atrial septal patch, a little bit onto the right side, so I give us a reasonable orifice entering into that left-sided AV valve. I'll typically split the papillary muscle to try to allow them to grow apart. And what I've noticed is pretty impressive. Sometimes you can actually grow a mural leaflet by splitting the papillary muscles and allowing those papillaries to separate over time. So that when you come back a year down the road, you can close the cleft. You have more you can do with that left AV valve. The ventricles don't have endocardial fibroelastosis, so they tend to grow much easier than, as Dr. Barucham mentioned, the HLHS patients. These left ventricles will respond quite impressively. And again, we look at the response of the ventricle to decide how to go. So if I do an atrial septal defect restriction, keep the VSD open, might adjust the PA band, or if there's a stanzol, keep the stanzol. And then notice that generally within 10 months to a year, we'll get the growth of the left side or the right side if it's a left dominant that we're looking for. And at that point, we can come back and close the VSD and complete the biventricular circulation. If it hasn't grown, then there are some other strategies. Sometimes you have to restrict the ventricular septal defect as well. And we might do that at the time of the original operation or at a subsequent operation. But ultimately, I've found that in my experience, probably somewhere around 75% of these patients will recruit. There are probably 25% of patients that don't demonstrate adequate response. But to me, that's, if you're saving 75% of those patients from going to a single ventricle palliation, that's a huge benefit.
Well, thank you for that great discussion. Let's move on to our last lesion that we're going to discuss today, which is double inlet left ventricle and double inlet right ventricle. Dr. Barucham, can you get us started on how we evaluate these patients?
Sure. These patients can have a really wide variety of like looping and great artery anatomy. So I find that these patients really need to be evaluated very individually, and they all come to us with kind of a different circumstance in terms of whether or not they are poor Fontan candidates. I think one of the first things that we always ask in this group of patients are whether or not they have risk factors for Fontan, because then it really is a discussion about what are the benefits and risks of Fontan versus the benefits and risks of double inlet ventricle septation. They both certainly carry their own risks. But we've had a number of patients who are poor Fontan candidates, and that certainly will kind of push us more towards consideration of ventricular septation. So again, we go through our typical imaging. So we'll often get a cardiac MRI. And with that, we often use certain types of contrast so that we can generate these beautiful 3D models, which kind of give us a sense of the relationship of the AV valves to the ventricle, the position of the bulboventricular foramen, how the alignment of the great arteries. And really, it's looking at that three-dimensional anatomy of the heart is where we start to devise where we think a patch could potentially be placed and how successful that patch will be. There are a lot of situations in which the AV valves share papillary muscle, or they have straddling chordal attachments between the two AV valves. And we consider that to be slightly higher risk in terms of septation, because in order to place a patch to fully septate, you'll have to split that papillary muscle, and that could affect AV valve function. Again, the other thing we look at is the arrangement of the great arteries. Now, in this example, this is basically a Holmes heart in which we have both right and left atria drain to the left ventricle, and then we have normally related great arteries and a pulmonary artery band. So this is actually one of my patients. And so again, we look at the size and function of the ventricle. Actually, prior data has shown that the larger the ventricle, the more likely, the higher success with ventricular septation. Again, we look at the morphology of the AV valves in terms of not only the leaflets, but the chordal structure, the papillary muscles, where they're located, whether or not they connect, the anatomy of the outflow tracts, and as I mentioned, risk factors for Fontan. And then we often will generate these 3D models and try to place a virtual patch just to see kind of how that septation will occur. And then this is just, an example of my patient. I showed you the 3D model earlier. So this is the double inlet left ventricle here. Preoperatively had a pulmonary artery band placed. And then at 13 months of age, this patient came back and underwent a Glenn procedure with a septation. She does have some residual ventricular septal defect, but in fact, her physiology is really great. Her stats are in the high 90s. She's clinically doing really well. And so this really is an option for many of our patients. I believe that was it. So yeah, we can now move on to Dr. Amani's part.
Excellent. Then Dr. Amani, can you tell us what the surgical options are for these children?
Yeah, so I'd like to step back and sort of say that septation for double inlet ventricle was attempted back in the 1980s, and it was abandoned when the Fontan procedure kind of became popularized. And I think the reason for that is because the Fontan was much simpler, and at that time there was a high risk profile for septation, high risk of complete heart block. And I think the issue at that time is we were trying to do septations all in one go. So put a patch in, complete the septation, and completely unobstruct the right side of that. And what we noticed was that this septum was very non-compliant. You could imagine that large piece of patch just sort of bowing over into the right side of the heart. And so, I like the Doors, and I wear bell bottoms too. So we're all going retro here. And so I also, at the same time, thought that there was actually some advantage to thinking about septation for the appropriate patient, and dug back into the literature and pulled out some of those old reports. And what we realized is that, all of a sudden loading this ventricle with a septation probably was the wrong maneuver. And so trying to do this in stages was kind of one of the innovations that we started to look at. So the idea here is that, again, you have a patient who may have a PA band or have a DKS. We do a partial septation in order to place a patch that will separate the ventricle into two separate chambers, a right and left side, but leave a significant ventricular septal defect in place. So that patch basically stays centered with equalized pressures on both sides. It doesn't bow back and forth because there's a large enough VSD. You still retain a PA band or a DKS so that the right side and the left side are under equal pressure. You start with that. Now you let the child grow, and with that, the patch sort of incorporates. There's still some residual VSDs, but you have favorable streaming, so your SATs are better. And once the child has grown and out of their PA band, you can come back and close the residual VSDs and complete the septation. What we've noticed is when we've done it, when we do it this way, we don't have as much septal billowing from that patch because there's more incorporation. And so what we started doing is really taking the staged approach, looking at the response of the ventricle over time, and then completing the septation at a later time point. Again, all the while not burning any bridges for a single ventricle palliation if it turns out that that we're not happy with the ventricular dynamics. I think one of the issues with septation is the risk of complete heart block. And we haven't completely solved that problem, but we've significantly made a dent in it. At some point in the 1980s, there was a nearly 80% or 90% chance of heart block. And we've developed these intraoperative mapping tools. You can sort of see here in this video panel, us using a grid that's used in the EP lab to help identify location of the conduction system. And that's where we basically avoid suture placement. That's where we leave our VSD. Place our patch in such a way that we avoid that conduction system as much as we can. We still have about a 15% rate of heart block. There's no doubt that remains one of the risks of this procedure, but I feel like using mapping has really made a big dent in that and really allowed this to be something that is that's a viable option for a patient that we're trying to avoid a single ventricle palliation long term. So again, we're close to 30 to 40 patients now that have undergone this type of procedure, and overall it's been successful in that we've been able to avoid a Fontan and avoid a transplant in patients with this anatomy. So it's kind of exciting. We're still developing some new techniques to make this even better. And overall, I've been optimistic with the way that things are going with this.
Well, thank you both so much. So before we move on to our next topic, I just want to mention this is not an extensive list of lesions, as Dr. Barucham showed in her first slide, but the ones that we chose for today. As we move on to our next topic, we will focus on the unique aspects of our approach for complex biventricular repair here at Boston Children's Hospital. Dr. Mahdi, what surgical innovations in the complex biventricular repair have made it possible to treat a greater range of single ventricle conditions?
Yeah, I think there have been several key developments. First is, as you see on the left there, our ability to really image with three-dimensional modeling complex pathways and to develop really novel ways to create pathways. I think along with that includes the ability to baffle venous structures, SVC, IVC, in a way that doesn't cause obstruction, but also to baffle LV to aorta, even remote aortas, knowing how to reposition aortas, knowing the different strategies that can allow for that. And the three-dimensional modeling for these pathways has really helped us with that. As I mentioned earlier, the intraoperative EP mapping has been very helpful. We've now done that in over 300 patients. And our rate of complete heart block in these very, very complex patients has dropped from 15% down to under 7%. and in some of our heterotaxy patients down to 3%. So that is a significant advance. I've found that I've not been putting in as many pacemakers anymore. And I think that helps long-term even with the ventricular function. So I think that's been important. And then finally, our ability to handle the valves, novel valve repair techniques, using the imaging to guide very specific management. I find myself using more artificial cords, for instance. We're using some of the partial heart transplant technology, valve transplantation techniques to help with valve repair. And I think with advanced imaging, modeling, and valve repair techniques, it's really transformed the way that we think about biventricular repairs. Next slide. One really cool technology that's being developed is 3D patch planning for these complex pathways, for instance. So we now have a team of engineers that basically evaluates every BIV patient, and we can develop these 3D patches and use an intraoperative laser projection to help plan out the size and shape of the patch to basically tailor it to that particular patient's anatomy. So these are some examples of some really cool engineering tools. I love gadgets. I love new technology. I especially love it when it can help a patient and improve outcomes.
Thanks, Dr. Amani. These are some really amazing things happening in the operating room. Dr. Barucham, what other innovations have facilitated complex biventricular repair here at Children's?
Thank you. Yeah, so I just want to kind of mention that globally within our heart center, complex biventricular repair, we think of it as a heart center wide initiative, and really it touches on all of our individual subspecialties within cardiology. So and just runs the gamut all the way from, our intensive care unit, our advanced cardiac therapies team. We have a heterotaxy program here as well that sees a lot of our patients, all the way to our scheduling. And so, just having the whole heart center really be involved in these patients and really interested in complex biventricular repair, I think has raised the bar and just kind of raised the level of care in general for our patients. And so just focusing on these three programs, one, the heterotaxy program, our heterotaxy program will meet with our heterotaxy patients. We have a nurse practitioner who's dedicated to this program, and she spends a long time with families just providing counseling about heterotaxy syndrome, what are all the associated lesions, and then getting them in touch with some of the other care providers within our heterotaxy program. It's testing for primary ciliary dyskinesia. And then we, in fact, even have a heterotaxy program in our ICU in terms of, managing respiratory issues postoperatively. And then we've really very closely involved our advanced cardiac therapies program. We've kind of, as part of this, we developed a heart failure prevention protocol, and we call it our vulnerable myocardium clinical pathway. And it's basically an evaluation for ventricular dysfunction both before and after complex biventricular repair. And just kind of it helps us understand when do we need to initiate advanced cardiac therapy support. We do this sometimes preoperatively. So if we notice that a ventricle looks very vulnerable in one way or another, we'll sometimes involve this team, and we sometimes will start guideline-directed medical therapy in our patients prior to either considering or proceeding towards a biventricular repair. And then postoperatively, we pay very close attention. What we don't want to happen is to do a biventricular repair, send our patients out, and then not really hear back from them and find out later that there's a problem with their myocardium and they've developed some type of cardiomyopathy. And so we, again, we like to try to stay on top of these patients and really kind of assess their hemodynamics postoperatively, and then consider starting additional medical therapy earlier rather than later. And then we have a really very close relationship with our ICU folks, as well as our electrophysiology team. And so most recently, we've begun to implement an arrhythmia prevention protocol in our complex biventricular repair patients. And so again, this whole approach it covers really all aspects of our heart center.
Thank you, Dr. Broken. It really seems like the entire Heart Center has jumped in for this program. What is the short and long-term outcomes of biventricular repair, and what are the risk factors for adverse outcome?
So I think I'll touch on that. So, as Dr. Ramani mentioned, this started with Dr. Del Nido in kind of the early 2000s, and you can see that our trends in biventricular versus Fontan volumes have really flip-flopped compared to the early 2000s. And so we really have quite a large number of patients now in whom we've offered either 1.5V or full complex biventricular repair. Now I'm showing you a mortality curve here that we have developed a real-time dashboard that looks at our database, and we can actually manipulate it in real time, and we can use this in our conferences. And so this particular graph that you're seeing here was actually, I produced this in a few minutes by just typing in, 1.5V and 5V, and then it gave me these statistics. But this is really in line with a lot of what our publications have shown, which is that for the entire cohort of our patients, long-term survival is probably in the range of 85 to 90%. Now, it really depends on the individual lesion. And so, I'm showing this graph, but really I think it's more important to sort of understand the individual patient and what are they coming in with. So for example, a patient with heterotaxy syndrome and very complex venous anatomy, in addition to, AV valve dysfunction, may be at higher risk for a complex biventricular repair compared to, for example, a patient with Down syndrome who has like mild left ventricular hypoplasia. So, I don't necessarily love to show graphs like this. It's really more important to look at the individual lesions and sort of think about patients individually. And this is actually why we have our dashboard. So in our dashboard, we can sort of filter by diagnosis and then by a particular surgical strategy. And then we can compare different strategies to each other and kind of look through our historical cohort to try to understand. And so honestly, that's what we're using that more often now in terms of counseling our families because they really want to know what are the outcomes. The other thing I just want to mention is that we are also collecting parent-reported outcomes. So we're using the pediatric cardiac quality of life measures, and we're kind of actively trying to collect those outcomes in our patients so that we can really understand. We're not just talking about mortality, but we really want to understand what is their quality of life.
Awesome. So Dr. Mani, what do you see as the future direction for innovations for our complex biventricular program?
Well, I think clearly we need to understand how to treat and prevent endocardial fibroelastosis in our HLHS patients. I think, as I mentioned earlier, there are some novel pharmacologic agents that, in the lab we've been working on, including dapagliflozin and losartan, which are medications that we sometimes now start for some of these patients. But to understand what the role is for novel biological therapies, we've completed a recent randomized clinical control trial looking at the effect of stem cell and mesenchymal stem cell transplantation. And I think we're going to be seeing that become more prominent to improve diastolic dysfunction in some of these patients. Many of them, the ventricles are not normal. I think we are continuing to fine-tune our algorithm based upon what we're learning about the response, and I feel like it's really accelerated over the past few years. And finally, I think we need to figure out ways in which we can disseminate this knowledge more freely. I think I'm starting to feel more confident in the outcomes, and we need to share this more with folks. And one of the reasons why we're starting this webinar series to kind of share some of the ideas that we have and to learn from others.
Thank you. So as we wrap up our webinar, we'll just review the referral process for providers. Dr. Baruka, when should a provider consider reaching out to the Complex Biventricular Program for patient referral?
I would say that we welcome referrals like at any stage during a child's development. So as early as a biventricular repair may be considered, we're happy to review the case. We have a conference that we host once a week, and we discuss all of our cases. And really, sometimes the earlier the better, because we have seen some situations where a patient underwent single ventricle palliation, and then it wasn't until they were 10 or 12 years of age that now they're asking a question whether or not we can proceed towards a biventricular approach. And we typically like to do these repairs kind of in the younger years. So typically by 2 or 3 years of age, we like to have completed the biventricular circulation.
I would just add to that by saying if you're thinking about whether or not a BIV may be possible, if you're asking the question of, I wonder if this LV, could ever make it, or if this anatomy could ever be a BIV, versus a single ventricle. There are no strict criteria, but if you think that, wow, could this ever happen, then it's the right time to be sending a patient. I feel like, we didn't talk about some of the other lesions, including complex transpositions, straddling valves, hypoplastic ventricles with heterotaxy, small right sides. But I agree. If ever any question, we welcome sort of getting images and seeing what things look like, and we're happy to review it quickly and get back to you.
And let me just get into some of the specifics of how a provider can refer. So they can make a referral by going onto our website and requesting a second opinion, or by directly contacting our biventricular coordinator, Sihan, whose contact information is on the slide. Our coordinator will help with getting all the images transferred to our system. We will then ask for echocardiograms, catheterizations, MRIs, and CTs, and the most recent cardiology note. Once all this information has been compiled, as we talked about, we will discuss them at our biventricular conference. This conference allows both our cardiologists and surgeons to review the images and give a comprehensive review of each case referred. Referring providers are welcome to join this conference and participate in the discussion. From our discussion, a letter will be generated that just summarizes our discussion during conference. So, Dr. Mani, what happens after a patient is referred to Boston Children's Hospital for surgery? What communications and partnerships do we develop with the local provider?
Well, I think it's really important to, from the very beginning, have open discussions about what's the best thing for the patient. That's what we're all here for. We like to start that process early on with discussions with the entire team, and sharing what we know, what we don't know, and I think at the end of the day, this really helps the families think about this approach and make the right decision, whether or not it's to try a biventricular repair. We like to continue that relationship afterwards, because once we've done a recruitment or a biventricular repair, as Dr. Bruckham mentioned, we'd love to kind of stay involved, and that's very easily done nowadays with our communication portals, and so love to stay in touch with the local teams and families.
And Dr. Bruckham, just to segue into that, how do we continue to work in partnership with our local teams?
Thanks, Naomi. Yeah, so we really value the local cardiologist, and we work in partnership with them. So I like to stay in touch with all my patients' local cardiologists. I like to receive follow-up information, oftentimes imaging, and help provide some guidance. So we don't like to fully assume care for patients who are referred to our center. Really, we find it imperative for our patients to have their own local cardiologists. Should we move on to answering? There's a couple questions in the chat.
So I think one of the questions from the chat is, for the unbalanced AV canal patients, can you describe why you choose to close the ASD, but leave the VSD open, or perhaps restrict the VSD instead of closing the VSD and fully restricting the ASD?
Maybe I can address that. That's a great question. So when we first started recruiting unbalanced AV canal patients, we thought that we had to close, or at least partially close, both the VSD and the ASD to promote flow into the hypoplastic ventricle. One of the issues, of course, with closing the VSD is if you have a PA band, that some of the cardiac output is supported by that right ventricle. So if you close the VSD completely, then you eliminate that possibility and you're 100% relying on the left ventricle for cardiac output, unless you have a DKS or some other way. What we realized, though, is that you really don't need to close the VSD to get the ventricle to grow. And this was kind of an interesting thing that we observed probably about 8 or 10 years ago, that in a couple of patients where we just closed the atrial septal defect, somehow the flow profile created by that ASD closure was enough to make the ventricle grow. And so we moved away from closing the VSD at that time. It also eliminates the need for getting close to conduction system or adding an additional patch that could be restricted and restrict cardiac output. And it simplified that initial staging procedure significantly. There are still a few patients in whom we need to close the VSD partially. You have to, and those are patients in whom the left-sided AV valve still flows into the right ventricle, despite the fact that we've closed the atrial defect.
Thank you so much for that. We have another topic that we didn't really get a chance to take to really dive into, but pressure volume loops and surgical planning. How has this helped with timing of procedures?
So I'm happy to kind of talk about how we use pressure volume loops specifically in our patients with CCTGA. And so we've started to do this in our patients with CCTGA and intact ventricular septum. And the challenge is that it's oftentimes difficult to predict who is going to develop left ventricular failure following a double switch procedure. So there's some traditional metrics that other investigators have looked at, such as the peak left ventricular pressure and the LV versus RV peak systolic pressure at cath prior to the double switch. But we've begun to look at pressure volume loops, which it sort of adds a little bit more information. It adds to pressure, and it really looks at stroke work of the ventricle. And what the whole theory behind this is that the right ventricle in a patient with CCTGA is already supporting a systemic output. And so the PV loops will sort of compare what the left ventricular stroke work is to the right ventricular, the current patient's right ventricular stroke work. So it's sort of like an internal control. And by evaluating that, we've sort of developed some cutoffs for what we think are appropriate times when you can proceed towards a double switch operation. We'll usually do those PV loops when we're truly considering doing the double switch. So it's typically after a PA band or in a patient who already has what we believe is high left ventricular systolic pressure. Those are the situations when we'll typically do those PV loops. I don't know, Dr. Armandi, if you wanted to add to that at all.
No, I think the other patient population, patients with hypoplastic left heart syndrome, there the issue is really understanding the diastolic function of the ventricle and how much of it is volume loading or unloading. I would also add that there's a whole body of work that we didn't talk about in this webinar that I'm sure we'll get to at some point, is taking down the Fontan, and when can we take down a Fontan to a biventricular repair in a patient. And I think in that situation, the pressure volume loops will be very helpful. I think the situations in which they're not helpful are where there's a large VSD and we're trying to assess ventricular function. With the VSD, the impedance catheters can't give you isolated information. And so for that, we're trying to look at newer techniques using MRI combined with pressure measurements, hopefully to help us with that.
Actually, just to bring us to Fontan takedowns, I know we didn't get to discuss this, but Dr. Barucham, have you developed a kind of a method of how we evaluate those patients prior to Fontan takedown?
Thanks, Naomi. Yeah, so the Fontan takedown really is kind of one of the most complex discussions and considerations for biventricular repair. Because as we know that as patients age, their diastolic function declines. And then for our older Fontan patients in particular, their ventricles often, both ventricles become small because they're only pumping sort of half of what the necessary stroke volume would be. And so again, the whole thought process towards making a decision towards complex biventricular repair is sort of predicting how a patient will do after their circulation is changed abruptly. So the Fontan patients, we've developed a protocol for evaluating those patients where we bring them to the hospital, and then we basically perform all of the imaging that I've already discussed. So we'll do echocardiography, we often do cardiac MRI or CT, and then we do cardiac catheterization. And then I've also been doing cardiopulmonary exercise testing and blood work and all of that, and we've been evaluating their liver. So basically like a really comprehensive Fontan evaluation to look at, how are they doing as a Fontan now? And then are there ways that we can improve their circulation? There's some situations where we feel like patients are potentially better candidates for a biventricular conversion compared to others. And we're starting to get a little bit of knack for this now that we've evaluated so many patients. I would say that, of 10 patients who we evaluate, maybe we proceed with about 1 out of 10. So it's not like we're doing this procedure in a huge cohort, but we certainly are doing numerous evaluations. And I'm hopeful that in the next 5 to 10 years, we'll have a little bit more information about who are really the most appropriate candidates.
Great. Thank you both for those answers. I just wanted to ask, so why should I refer my patients to Boston Children's Hospital if I'm a referring provider to both of you? What makes our program different from others?
Well, I think if I may, Dr. Barucham kind of touched on the multidisciplinary approach, and I think this has really allowed us to develop highly specialized care teams around the care of these patients, and I feel like our volume of biventricular repairs is high enough that we really understand a lot of the nuances. And this is not something that one should be doing, a couple times a year. This is really an evaluation and a procedure that requires quite a bit of experience and intuition. So, at the least, I think for the decision making, I'm happy to sort of think about ways of partnering with local institutions to have surgeons do certain parts locally and refer for parts that are more technically challenging. And I do this at a national level. I speak very frequently to surgeons across the country and try to help mentor, and always happy to do that. I think that's going to be important moving forward. But those are some of the features that I would advance as reasons to at least tell us if you have a patient that you're interested in being evaluated.
Yeah, and I mean, if I can just add to that as well, because we have such a breadth of experience in complex biventricular repair, we do a lot of second opinions, and so we're happy to just take a look, and provide an opinion, and just provide that resource kind of to the community.
Well, I just want to say, I want to thank you both for this very exciting webinar. And as we conclude this in-depth conversation, I just want to let all the audience know that this recording will be added to our BCH YouTube page, and there will also be additional information for families there. And you can go to our website for additional information. So thank you all for joining, and thank you, Dr. Barucham and Dr. Amani, for this great discussion.
Thank you.
And I want to add that Naomi is our dedicated by VPA, and she really is very open to communication as well. Loves to kind of talk both with families and with referring providers, and is a great resource. So thank you, Naomi, for your dedication to the program.
Thank you.